There you go.
Hi, this is Jerry Hesch at the Hesch Institute in Henderson, Nevada, and this is a most remarkable case. And prior to him coming to see me, I was very concerned about the description of his presentation, and I'm pleased that based on the evaluation today, I feel very confident that we can make some difference in his presentation, and I think that we will learn much. And my optimism is such that I hope that the work we do throughout his lower extremity will have a distinct impact on the mobility in his pelvis. This is a fitness professional of some renown who has lectured all over the place for many, many years. And as a kid, at age 2, was climbing up trees, age 5, jumping into the ocean from a cliff and such. I mean, just crazy daredevil personality. Obviously had some early life significant injuries. But the name of this presentation, just to give you a little background of why he presents as such, is potential reflex relationship between the ankle, in which he has a talus restriction, hip restriction, and bilateral sacroiliac or pelvic motion restriction. The question we're asking, is the sacroiliac or pelvic restriction treatable? And I'll make sense of that title shortly. So if you would put both legs out straight, and what we find down low is we find a restriction of passive movement in which the left ankle dorsiflex is greater than the right ankle, and we find that the right ankle plantarflex is more than the left one. I'm going to defer demonstrating strength testing. Now the right talus, I can get some spring mobility once I take the slack out. I'm sure you can't see that. The left talus feels like I'm pushing on a brick, and if I slide up onto the distal tibia, it feels the same way. His subjective description is very close to what I experienced. He felt like the tibia was actually shifted medially into adduction. I perceived that the talus got stuck posteriorly. It got stuck in end range of dorsiflexion, almost as if you stepped onto a curve forcefully, but only caught the forefoot, and so it forces the ankle into excessive dorsiflexion. This essentially locks up the subtalar joint. On his right ankle, he has free and clear subtalar mobility, including ab and adduction, which you'll see in the foot, and also varus and valgus in the calcaneus. On the left side, there's just no give. I mean, very little. And if I try and abduct and I can't get him past neutral, if I try and adduct, he goes maybe 5 degrees. What does this have to do with his pelvis? Well, if you'll focus on the pelvis now, he has absolutely no passive accessory motion in the pelvis per orthopedic stress test, which we call spring test. For his age and body type, activity level and such, I should be able to glide this pelvis over. And I cannot. I can't glide it from the left to the right. If I try and create mobility through that structure into the lower extremity using normative forces, it's like I'm trying to push a block of granite. And if I try and rotate it posteriorly, same phenomenon on the other side. So I started to contemplate that maybe one of his severe traumas early in life caused enough damage that his SI joints fused. But as I started to peel some of the onions of this layer, I started to wonder if we treated the ankle and the hip, which I'll demonstrate shortly. Is it possible that this could be a reflex adaptation and that maybe this mobility will enhance? What this twisting of his pelvis basically does is it basically gives him a longer right leg. Because this is described in the nomenclature as a right anterior ilium, left posterior, although I describe it as a twist of the whole pelvis, not necessarily inside the sacroiliac joint, but it has the same effect in which it blocks motion going through the sacroiliac. I'm not going to belabor that concept. We've talked about that at length in other presentations. So what I want to show you now is this similar spring test done in prone, and I want to show you how he has two different hip joints. However, in this context, his hip mobility is really good. And by his description, I thought we were going to find real distinct hip pathology, but that really is not the case. He does present as though he has two different hip joints, but realize there's a twist in that pelvis, so the behavior of the hips will be different. In essence, there's some subtle difference side to side that's not worth detailing at this time, except what I'm going to show you. Would you lie on your stomach, please? When I bend his right knee, observe the pelvis and observe the hip. Little bit of glute contraction there, okay, and a little tiny bit of transverse plane pelvic rotation. Watch this side. Let me do this. I'm going to do this passively if I can. Right here we get a tremendous amount of pelvic rotation as we go further up. That's just really profound, and that's very consistent with repeat testing. The other thing that we find is that he has a adequate amount of right hip extension. I think we can gain a little bit by treating it. On the left we have a very distinct lack of passive hip extension, and I sincerely believe that we can improve that. And the spring test through the pelvis, again, it's like a block of granite. I can put 20, I can put 30 pounds of force and not get any movement. Here's a thrust on the sacrum. Here's a thrust, an effort at a thrust lower and upper. He did have a lumbar fusion not too long ago, which is solid, and long history of weakness in the right lower extremity, difficulty flexing that hip, etc. He's worked very, very hard to overcome those. Has some issues in the upper body, neck and shoulder and forearm. I'm not going to detail those. Interestingly, the sacrotuberous and sacrospinous ligaments are very, very tight. And if I palpate the ligaments right under that PSIS, they feel more like bone than ligament. Here's the sacrotuberous. And it should bounce a little bit, but it doesn't. These are just rock hard, okay? If I try and spring his pelvis superiorly, nothing. And this is a very reasonable amount of force in which you would see that with most clients. So we're going to stop filming here. I'm going to treat his left ankle and left hip. If I decide there's a little bit of a restriction in the right ankle in the opposite direction, I might treat that. The question I'm asking is, simply because I have seen this in the past. I saw it this weekend when I was teaching in Philadelphia, in which I restore mobility in somebody's subtalar joint, and there's an incredible, surprising, remarkable increase in mobility in the pelvis. Had a case this weekend teaching, and I thought his left SI was fused because I couldn't get any motion through it. And when we unlocked the talus, the pelvis let go. It was a reflex-driven phenomenon, and the innervation of the posterior SI is very similar to the innervation of the posterior talus. That's all I'm going to say about that, and so we'll stop filming here and we'll treat him, and we will see if in fact there are relationships that allow us to treat distal, treat the hip, and gain pelvic mobility. Thank you.